Osteoporosis. Osteoporosis is one of the greatest hazards of the postmenopausal years. It's characterized by decreased bone density, leaving the bones porous, fragile, and susceptible to fractures. The vertebrae, wrists, and hips are the most common sites of fractures, with forearms, feet, and toes also susceptible. More than 53 million people in the United States today either already have osteoporosis or are at high risk because of low bone mass. Osteoporosis can occur at any age, although the risk for developing the disease increases with age. Osteoporosis is most common in non-Hispanic white women, but the disease affects many older Americans of any race or sex. Hip fractures increase the risk for reduced mobility and death in the elderly. Risk factors. A combination of peak bone density and the rate of bone loss influences the severity of osteoporosis. Small-boned, fair-skinned white women of Northern European descent and Asian women are at greatest risk for osteoporosis, but African American and Hispanic women also are at risk. Other risk factors may include a family history of the disease, late menarche, early menopause, and a sedentary lifestyle. Women who smoke, drink alcohol, or consume excessive amounts of caffeine have an increased risk for osteoporosis. Drug intake such as corticosteroids, some anticonvulsants, or aromatase inhibitors for breast cancer may reduce bone density. Inadequate lifetime intake, calcium or vitamin D is a risk factor. Women usually reach their peak bone mass between 18 and 25 years. Bone loss in women usually accelerates with menopause. Osteoporosis occurs as a woman loses too much bone, makes too little bone, or both. Signs and symptoms. Osteoporosis has been called the silent thief because bone mass is lost over many years with no signs or symptoms. The first noticeable evidence is loss of height and back pain that occurs when the vertebrae collapse. Later signs include the dough wagger's hump, which occurs when the vertebrae can no longer support the upper body in an upright position. Secondary to this, the waistline disappears and the abdomen protrudes as the ribcage moves closer to the pelvis. Depending on the number of fractures, several inches of height may be lost. Figure 27.3 illustrates progressive changes in posture associated with osteoporosis. Diagnosis of osteoporosis requires a thorough history, physical examination, and bone mineral analysis. Dual energy X-ray absorptiometry, DEXA or DXA, is a highly accurate, fast, and relatively inexpensive method for measuring bone mineral density and involves low exposure to radiation. Results can be evaluated with risk factors to direct management. Bone density examination can not only confirm the presence of osteoporosis, but also detect low density before a fracture and predict the risk for fracture. Repeating bone density imaging helps determine the rate of bone loss and monitor treatment effectiveness. Prevention and medical management. The major goal of treatment is to prevent or slow osteoporosis and stabilize remaining bone mass. Although research has upheld estrogen therapy to reduce osteoporosis by inhibition of bone resorption, fewer women are choosing hormone therapy because of its potential adverse effects. In addition, many breast cancer survivors take medications such as aromatase inhibitors that suppress or block estrogen because of its effects on tumor cells. Drug therapy. Drug categories to reduce osteoporosis include the following: calcitonin, calcimar, miacalcin, Fortical. A synthetic hormone is usually prescribed as a daily nasal spray to reduce factors that cause loss of calcium and increase reabsorption of calcium in the GI tract. Biphosphonates inhibit osteoclasts, reducing bone turnover. Alendronate Fosamax, Risadronate Actonel, and Ibandronate Boniva are used to prevent and treat postmenopausal osteoporosis. Oral bisphosphonates may be contraindicated for women with ulcers or an inflammatory GI disease such as dysphagia or esophagitis. Alendronate and risedronate are also approved to treat bone loss that results from glucocorticoids and to treat men with osteoporosis. Zoledronic acid, reclassed, is approved for treatment of postmenopausal osteoporosis and is given by IV infusion yearly. Headache or flu-like pain in muscles or joints may occur for 2 or 3 days after zoledronic acid infusion. Raloxifene, Evista, a selective estrogen receptor modulator, or SERM, binds to estrogen receptors to reduce bone loss. Because of the combined estrogen agonist and estrogen antagonist effects of SERMs, raloxifene is being studied to see if its effect also improves cardiac health without raising breast or uterine cancer incidence. Teriparatide, Forteo, is an injectable parathyroid hormone approved for postmenopausal women and men at high risk for fracture. Current approved duration of use is a maximum of 24 months. Teriparatide stimulates new bone formation, reducing the risk for both vertebral and non-vertebral fractures. Nausea, dizziness, and leg cramps are side effects. Denosumab, Prolia, is a recently approved receptor activator of nuclear factor kappa beta, rank, ligand, rankle, inhibitor that inhibits osteoclasts. Increased rankle in postmenopausal women results in greater bone resorption with the osteoclasts. Denosumab reduces bone loss by inhibiting osteoclasts produced by higher rankle levels. Calcium and vitamin D. Although calcium does not prevent bone loss, other therapies cannot be effective if calcium is deficient. A woman 50 years of age and younger needs 1,000 milligrams of calcium daily, and a woman 51 years or older needs 1,200 milligrams daily. Daily calcium supplements are recommended because it is difficult to ingest these quantities through food intake only. Vitamin D is necessary for calcium to be absorbed from the intestine. Supplemental vitamin D, 400 to 800 units, is often recommended for women under 50 years of age. 800 to 1,000 units is recommended for those 50 years of age or older. Exercise. Weight-bearing and resistance exercise has been shown to be beneficial in slowing loss of bone mass to maintain density if there is adequate calcium and vitamin D intake. Most of the bone mass is acquired by age 18, but muscle strengthening exercise may continue to build bone into the 30s. High-impact exercise improves bone mineral density but should be avoided in a person who already has fragile vertebrae from osteoporosis. At least 30 minutes of daily therapeutic exercise is needed. Other exercises, such as swimming or water-based exercises, often improve cardiovascular and respiratory fitness while managing weight, although their primary use is not to limit bone loss. Nursing considerations. Nurses often counsel women about lifestyle factors that contribute to bone loss, such as cigarette smoking, excessive alcohol or caffeine intake, and the importance of following the recommended medical regimen. Adolescents and young women should be counseled about factors that impair as well as promote their ideal amount of peak bone density. Nurses are also concerned about how to prevent falls and thereby reduce the risk of fractures, particularly in older women or those with mobility impairments. A major responsibility is to help the woman make her environment as safe as possible. Lighting should be ample, with switches easily accessible. Loose electrical cords should be kept out of the way An area rug should have non-skid backing. The bathtub should have non-skid devices, and grab bars should be installed near toilets and tubs. Stairways should have handrails, and loose items should be kept out of the walking pathways. Consultation with an occupational or physical therapist may be needed if the woman has serious mobility problems. Pelvic floor dysfunction. Pelvic floor dysfunction occurs when muscles, ligaments, and fascia that support the pelvic organs are damaged or weakened. This relaxation of pelvic support allows the pelvic organs to prolapse into and sometimes out of the vagina. Pelvic disorders generally occur in the perimenopausal period and may be delayed result of traumatic childbirth or the effects of aging. Although 50% of women over 50 years of age have some degree of pelvic organ prolapse, fewer than 20% seek treatment. Pelvic floor dysfunction may occur in a woman who had a hysterectomy. Vaginal wall prolapse. The vagina may prolapse at either the anterior or the posterior wall. Anterior wall prolapse involves the bladder and urethra and is called cystocele. Prolapse of the posterior wall produces enterocele or rectocele. Cystocele. When the weakened upper anterior wall of the vagina is no longer able to support the weight of urine in the bladder, cystocele develops. The bladder protrudes downward into the vagina, resulting in incomplete emptying of the bladder. Cystitis is likely to occur because of the stagnant urine. Urethral displacement, formerly termed urethrocoele, may occur when the urethra bulges into the lower anterior vaginal wall, producing stress urinary incontinence. Stress incontinence is the loss of urine that occurs with a sudden increase in intra-abdominal pressure, such as that generated by sneezing, coughing, laughing, lifting, or sudden jarring motions. The two most common causes of stress incontinence are damage to the normal supports of the bladder, neck, and urethra that occurs during pregnancy and childbirth, and tissue atrophy that occurs after menopause. Enterocele. Enterocele is prolapse of the upper posterior vaginal wall between the vagina and rectum. This is almost always associated with herniation of the pouch of Douglas, fold of peritoneum that dips down between the rectum and the uterus, and may contain loops of bowel. Enterocele often accompanies uterine prolapse. Rectocele. Rectocele occurs when the posterior wall of the vagina becomes weakened and thin. Each time the woman strains at defecation, feces are pushed against the thin wall, causing further stretching until finally the rectum protrudes into the vagina. Many rectoceles are small and produce few symptoms. If the rectocele is large, the patient may have difficulty emptying the rectum. Some women facilitate bowel elimination by applying digital pressure along the posterior vaginal wall to keep the rectocele from protruding during a bowel movement. Uterine prolapse. Uterine prolapse occurs when the cardinal ligaments, which support the uterus and vagina, are unduly stretched during pregnancy and do not return to normal after childbirth. This allows the uterus to sag backward and downward into the vagina. Uterine prolapse is less common than in the past, largely because of reduction in traumatic vaginal delivery. The condition continues to exist, however, particularly when the woman has had many vaginal deliveries or when the infants were large. Figure 27.5 illustrates 3 degrees of uterine prolapse from first degree, in which the uterus remains in the vagina, to third degree, in which the cervix protrudes from the vagina. Symptoms. Symptoms of pelvic floor dysfunction generally become obvious during the menopausal period. This is because estrogen diminishes at this time, resulting in atrophic changes in the supporting structures. The most common symptoms of vaginal wall prolapse are feelings of pelvic fullness, dragging sensation, pelvic pressure, and fatigue. Low backache and the feeling that everything is falling out are sometimes described. Sexual problems related to arousal, orgasm, painful vaginal intercourse may occur with pelvic floor dysfunction. Symptoms relate to the structures involved and the level at which support has decreased. For instance, urinary frequency and urgency, urinary incontinence are seen in patients with cystocele because support of the urethra and lower vaginal wall has decreased. Constipation, flatulence, and difficulty defecating are major symptoms of rectocele. Regardless of location or structure involved, symptoms become worse after prolonged standing and are relieved by lying down. Symptoms of uterine prolapse are produced by the weight of the descending structures and may include sensations of pelvic pressure, backache, and fatigue. Cervical ulceration and bleeding occur if the cervix protrudes from the vaginal introitus. Management. Treatment of disorders related to pelvic floor dysfunction depends on the woman's age, physical condition, sexual activity, and degree of prolapse. Surgical procedures provide the most satisfactory therapy for women who have significant discomfort. The most common procedures are the anterior and posterior colporrhaphy, often called an A&P repair. Anterior colporrhaphy involves suturing the pubocervical fascia to support the bladder and urethra when a cystocele exists. If a rectocele exists, a posterior colporrhaphy, suturing the fascia and perineal muscles that support the perineum and rectum is performed. Vaginal hysterectomy may be combined with anterior and posterior repair. Surgery is contraindicated. A pessary, a device to support pelvic structures, may be inserted into the vagina. The pessary should be inspected and changed frequently by a physician or nurse practitioner to prevent vaginal ulceration, fistula formation, stool impaction, and infection. Vaginal estrogen cream may improve the woman's tolerance of the pessary. Topical or systemic estrogen treatment may be indicated for the woman. Nursing considerations. Pelvic exercises. Pelvic floor muscle training is directed toward strengthening the levator, ani, and pubococcygeal muscles that affect urethral closure and pelvic floor support. Kegel exercises are isometric, and one possible application is for the woman to consciously contract and relax these muscles slowly 8 to 12 times for a count of 6 to 8 seconds each, and repeat this series for 3 sets. Before teaching pelvic floor muscle training, determine whether the woman can contract the muscles by asking her to sit with her legs apart while she urinates and to squeeze the muscles to stop the stream of urine. If she can accomplish this, the muscles are contracted and it is possible for her to perform the exercise. Muscles of abdomen, thighs, and buttocks should not tighten during pelvic floor muscle training. Women should be taught to exhale and keep the mouth open to avoid bearing down when contracting their pelvic muscles, and then gradually relax the muscle contraction. Variations exist about how frequently to repeat pelvic muscle contractions each day. To maintain pelvic muscle tone, the woman should continue pelvic floor Kegel exercises for the rest of her life. Graduated weight cones may be used as an adjunct to pelvic muscle exercise. Incrementally weighted cones are inserted into the vagina, and the woman attempts to hold the weights in place. As the weight of the cones increases, the resistance against which the pelvic muscles contracts increases, thereby strengthening the pelvic muscles. Measures that help reduce the symptoms of pelvic relaxation also may prove helpful. These include lying down with the legs elevated for a few minutes several times a day. Some women are relieved by assuming a knee chest position for a few minutes. In addition, teaching may include measures to prevent constipation. Urinary incontinence. Evaluation of the characteristics of a woman's urinary incontinence guides treatment. The following are 3 major patterns: Stress incontinence, with urine leakage occurring as the woman increases her intra-abdominal pressure. Examples of times when intra-abdominal pressure may increase sufficiently include coughing, sneezing, laughter, or physical exertion such as picking up a full shopping bag or heavier load. Urge incontinence, characterized by urine leakage that accompanies a woman's strong need to void promptly. Mixed incontinence, in which a woman's urine leakage has associated factors from both the stress and urge incontinence patterns. Overactive bladder, OAB, may occur with both urge and mixed incontinence. OAB is characterized by frequent sensations of urgency, and nocturia may accompany neurologic, anatomic, or structural disorders. Direct questions such as, do you have trouble with your bladder, or do you ever unintentionally lose urine, may encourage women to discuss urine control problems. After the subject is introduced, follow-up questions are asked to determine urinary frequency. For instance, can she sit through a 2-hour movie without emptying her bladder? How many times does she get up to urinate each night? Does she often feel she must hurry to empty her bladder and that she will lose urine while going to the restroom? Nursing research has shown that continence can be improved by teaching specific health promotion activities, such as pelvic floor exercises and bladder training, which involves adhering to a prescribed schedule for emptying the bladder. Women who cannot execute even a weak pelvic muscle contraction or are unable to implement bladder training may benefit from biofeedback or electrical stimulation provided by a skilled practitioner. Women often benefit from knowing about some of the commercial products that protect the skin and prevent odor. These products are made of material that traps urine and prevents constant contact with the skin. Women often restrict fluids, thinking this will decrease urinary incontinence. Restricting fluids may actually make the condition worse because the bladder does not fill to its normal capacity. Furthermore, decreased fluid intake can lead to concentrated urine that can irritate bladder mucous membranes and increase the urge to void. Alcohol and caffeine can irritate the bladder also and worsen incontinence. Obesity is associated with urinary incontinence, increasing the benefits for a woman to achieve her ideal weight range. Drug treatment may enhance bladder control. Drugs that may be prescribed include vaginal estrogen using a cream, tablet, or vaginal ring to reduce atrophy of the urinary and vaginal areas, anticholinergic drugs, including their long-acting versions such as oxybutynin, ditropan, and tolterdine, detrol. Other drugs are being studied for possible use in improving bladder control. Disorders of the reproductive tract. Benign disorders. The most common benign conditions of the reproductive tract include cervical polyps, uterine leiomyomas, fibroids, and ovarian cysts. Cervical polyps. Polyps are small tumors, usually only a few millimeters in diameter, that are generally on a pedicle, a stalk, or stem-like structure. They are caused by proliferation of cervical mucosa and often cause intermittent vaginal bleeding. Cervical polyps are surgically removed in an outpatient setting, and a specimen is sent for pathologic examination to rule out malignancy. Uterine leiomyomas. Leiomyomas, also called fibroids, are one of the most common gynecologic conditions encountered. Although the cause is unknown, they develop from uterine smooth muscle cells and are estrogen dependent. As a result, they grow rapidly during the childbearing years, when estrogen is abundant, but shrink during menopause unless growth is maintained by HRT for menopausal symptoms. Fibroids may occur throughout the muscular layer of the uterus and may be prominent near the end of pregnancy as the estrogen levels are high and the uterus is large. Uterine fibroids do not cause symptoms often. Uterine size is sometimes increased and excessive menstrual bleeding may occur. Excessive bleeding may result in anemia, weakness, and fatigue. Infertility may be related to uterine fibroids. Additional symptoms include feelings of pelvic pressure, bloating, and urinary frequency that occur when the tumor applies pressure on the bladder. Pressure on the ureter may cause hydroureter, dilation of the ureter. Many symptoms of fibroids depend on the location of the benign uterine tumors. Treatment depends on multiple factors, including the size, number, and location of the fibroids, the symptoms experienced, whether future childbearing is desired, and how near the woman is to natural menopause. In the absence of symptoms, treatment may consist of observation only. If abnormal bleeding is a problem, surgical intervention may be necessary. Hysterectomy may be appropriate for the woman who does not desire future childbearing. Myomectomy, or removal of the fibroid from uterine muscle, may be an option for the woman who desires future children. Uterine artery embolization, UAE, is a procedure focused on reducing the fibroid size by introducing obstruction in the arteries that supply the fibroid. Pregnancy after UAE is often more likely to have intrauterine growth restriction or preterm birth. Medical treatment with progesterone only or combination estrogen-progesterone oral contraceptives may reduce excess menstrual flow. Short courses of GnRH agonists may be effective in reducing the size of myomas and lessen symptoms before surgical removal. GnRH agonists cause hot flashes, vaginal dryness, and other discomforts similar to those of menopause and therefore are not tolerated well by some women. Loss of bone mineral density is an adverse effect of long-term therapy. Ovarian cysts. An ovarian cyst may be either follicular or luteal. If the ovarian follicle fails to rupture during ovulation, follicular cyst may develop. These cysts are usually asymptomatic and may be an incidental finding on an ultrasound. They generally regress during the subsequent menstrual cycle. A lutein cyst may develop if the corpus luteum becomes cystic and fails to regress. A lutein cyst is more likely to cause pain and delay in the next menstrual cycle. Occasionally, an ovarian cyst can rupture or twist on its pedicle and become infarcted, causing pelvic pain and tenderness. Treatment depends on differentiating a cyst from a solid ovarian tumor that is more likely to indicate cancer. If the woman is in her childbearing years and the risk for ovarian cancer is less, the physician may wait until the next menstrual cycle and examine the woman again. Transvaginal ultrasound examination is useful to determine whether it is a fluid-filled cyst or a solid tumor. Laparoscopy may be helpful in ruling out endometriosis. Laparotomy, visualization of abdominal or pelvic organs through incision, may be necessary to remove the cyst from the ovary for examination by a pathologist. Malignant disorders. Primary sites for cancer in the female reproductive organs are the uterus, ovaries, and cervix. Cancer of the vagina, vulva, and fallopian tubes is relatively uncommon. Although cancer can occur at any age, the incidence increases with age. Signs and symptoms. Cancer of the reproductive organs may not be diagnosed until it is advanced because few symptoms are experienced in the early stages. When symptoms occur, they are often nonspecific and could be caused by infection or other benign conditions. Cancer of the ovary is particularly difficult to diagnose because it may remain silent until far advanced, when the chance of long-term survival is greatly reduced. Risk factors. Risk factors vary according to the site of the cancer. Risk factors for cervical cancer include a history of STDs, particularly condyloma acuminatum, also known as genital warts, caused by the HPV. Prolonged use of unopposed ERT, estrogen only, predisposes to overgrowth, hyperplasia, of endometrial tissue, and is a significant risk factor for uterine cancer. See box 27.9 for a summary of risk factors for cancer of the reproductive organs. Diagnosis. Early diagnosis is strongly associated with long-term survival. Many screening and diagnostic tests are useful. Screening tests include periodic pelvic examinations, Pap tests, ultrasonography, and serum tests for tumor markers such as CA125, which may be increased with ovarian or other cancers. Genes linked to other cancers, such as BRCA1 or BRCA2 mutations, may lead to more diagnostic procedures than if the genetic risk is not apparent. Significant family history of specific cancers of the reproductive organs or linked cancers such as breast and ovarian cancers may alter the risk for a woman's development of cancer. Diagnostic procedures such as endometrial biopsy for endometrial cancer and colposcopy examination with a colposcope to magnify cells can identify patterns of abnormality near the cervical os, where most cancers of the cervix develop. Specific strains of HPV infection are a significant risk factor for cervical cancer, even if the original infection has healed. Management. Treatment of cancer of the reproductive organs is based on the location and extent of the disease and the age and desire of the woman to have children. The extent of surgical treatment for these cancers varies with the tumor size, degree of malignancy, and extent of spread beyond the primary tumor site. Chemotherapy and radiation oncology therapy supplement surgical treatment for many invasive cancers. Treatment of one type of cancer may be based on previous cancer treatment in the same or related organs. For instance, treatment of previous breast cancer with the chemotherapy drug adriamycin often means that the woman has reached the maximum lifetime amount that she can take because of the drug's effects on her heart. Drugs such as anastrozole, arimidex, and exemestane, aromatase inhibitors may reduce estrogen secretion that increases cancer growth in most breast and reproductive organs. Cervical cancer. Testing the HPV often reveals a cervical infection that contributes to cancer. Biopsy of the suspicious area and an endocervical curettage are done for diagnosis if the woman is not pregnant. A vaccine against the HPV strains that are most likely to cause genital warts and cervical cancer, Gardasil, has been released. HPV vaccine is most likely to be effective before sexual activity begins, the first dose of 3 being given at 13 to 26 years or as young as 9 years. A lesion of early cervical cancer is usually a squamous intraepithelial lesion, SIL. Early treatment of cervical cancer may consist of cryosurgery, destruction of abnormal tissue by laser, loop electrosurgical excision procedure, LEEP, or surgical colonization to remove the central cervix. Regular surveillance after cervical cancer therapy is recommended to identify recurrence, particularly in the woman who had a high-grade SIL whose risk for repeated cervical cancer is greater. Treatment for advanced cervical cancer usually consists of a total abdominal hysterectomy and bilateral salpingo-oophorectomy. Removal of the uterus and ovaries and sentinel lymph node biopsy may be done via laparoscopy. Adjuvant therapy with radiation and chemotherapy is likely. Endometrial cancer. Abnormal vaginal bleeding, usually near or after menopause, is the most common presentation for endometrial cancer. Cancer of the endometrium is the most common cancer of the female reproductive organs. The American Cancer Society estimates for cancer of the uterus in the United States for 2016 are that approximately 60,050 new cases of cancer of the body of the uterus, uterine body or corpus, will be diagnosed, and about 10,470 women will die of cancers of the uterine body. Although endometrial cancer occurs more often in a postmenopausal woman, about 1/4 of the cases may occur in premenopausal women. However, endometrial cancer in the older woman is likely to be more advanced. The highest cure rate is with surgery, hysterectomy, and salpingo-oophorectomy, followed by adjuvant chemotherapy and/or radiation therapy. Poor surgical candidates may be treated with only chemotherapy or radiation. Ovarian cancer. Women with ovarian cancer may be asymptomatic, or they may seek care for abdominal or pelvic pain, increased abdominal girth, sometimes abnormal bleeding. Total abdominal hysterectomy, bilateral salpingo-oophorectomy, and removal of ovarian tissue in the pelvis may be curative for women in the earliest stages of ovarian cancer. Surgery for more advanced ovarian cancer improves diagnostic information, allows more accurate staging, permits surgical reduction of the cancer. Ovarian cancer is usually treated by surgery followed by chemotherapy. However, it may be treated by chemotherapy to reduce the tumor size, followed by hysterectomy and bilateral salpingo-oophorectomy. A second surgery may be done to determine whether more surgical or adjuvant treatment is needed. Chemotherapy is required after surgery for all but the very early cancers. The 5-year survival rate varies with the stage of diagnosis in response to chemotherapy. Infectious disorders of the reproductive tract. Infections of the reproductive tract may cause a variety of problems for women of all ages. Although some, such as candidiasis, are mostly annoying, others, such as HIV, may be lethal. Some infections are seldom associated with sexual activity, whereas others are almost exclusively spread in this way. Infections may spread silently in the reproductive organs, allowing damage to the organs before the woman has symptoms. Candidiasis. Candidiasis, also known as moniliasis and yeast infection, is the most common form of vaginitis. The cause is believed to be related to change in vaginal pH that allows accelerated growth of Candida albicans, a yeast-like fungus commonly found in the digestive tract and on the skin. Some conditions, such as pregnancy, diabetes, oral contraceptive use, and systemic antibiotic therapy, result in changes in vaginal pH and flora that favor accelerated growth of C. albicans. Although not considered an STD, recurrent candidiasis in sexually active women may occur. A small number of male partners may have erythema and itching of their glans penis, balanitis. The main symptoms for candidiasis are vaginal and perineal itching. Vulvar and vaginal tissues are inflamed, causing burning on urination. Vaginal discharge is white, a typical cottage cheese appearance. Diagnosis is made by identifying the spores of C. albicans. Treatment may consist of non-prescription or prescription medications. Medications available without prescription include butoconazole, miconazole, clotrimazole, turconazole, and teoconazole by vaginal application. The duration for most of the non-prescription medications for candidiasis ranges from 3 to 7 days, depending on the specific medication. Women should be advised to seek medical attention with the first infection or if the infection persists or recurs frequently. Oral fluconazole is a prescription medication for treatment of candidiasis with a single dose. Patients with more severe candidiasis may need another dose of fluconazole in 4 days. Recurrent yeast infections that resist treatment are associated with diabetes or HIV. STDs. Many diseases can be transmitted through sexual activity. For some diseases, such as syphilis, gonorrhea, and chlamydial infection, sexual activity is almost the only method of transmission. For other diseases, such as bacterial vaginosis, sexual activity may or may not be the mode of transmission. Incidence. STDs are most frequent among adolescents and young adults because the vagina and microscopic tears in mucosa from intercourse provide favorable conditions for infection. Women are twice as likely as men to get an STD. The number of untreated infected individuals with no symptoms is most likely immense. For many reasons, these infections remain a major health problem despite advancements in the development of antibiotics. The age of the first sexual experience has been declining steadily. Sexual activity is high among adolescents and young adults. The immature vaginal mucosa of young adolescents is more easily injured during sexual activity. Multiple sexual partners, inadequate knowledge of transmission and prevention, and feelings of invincibility are common among this age group. Methods of contraception have a significant impact on the risk for STDs. Barrier methods such as condoms and female condoms offer the best protection from infection. Diaphragms, cervical caps, spermicidal foams, and jellies do not offer the same protection as condoms. Although they can decrease the risk for cervical and upper genital tract infections. When counseling teen girls and boys, nurses should emphasize that oral contraceptives can prevent pregnancy but do nothing to prevent exposure to STDs. Major concerns include the following: the vulnerability of women, especially teens, to STDs, the resistance of some organisms to antibiotics, the relationship between HIV infection and other STDs, failure of asymptomatic persons to seek treatment when their sexual partner is infected. Types of STDs. Trichomoniasis. Trichomoniasis is caused by Trichomonas vaginalis, a protozoan that thrives in an alkaline environment. Presenting symptoms include a purulent vaginal discharge that is thin or frothy, malodorous, and yellow-green or brownish-gray. The pH of the discharge is usually greater than 4.5. Vulvular itching, edema, and redness may be present. The diagnosis is made by identifying the organism in a wet mount preparation. Treatments of choice are metronidazole flagyl 2 grams or tinidazole Tindamax 2 grams in a single oral dose. Alcohol ingestion when taking metronidazole may result in a disulfiram-like antabuse reaction. Women should be advised to avoid using alcohol during treatment with metronidazole and for 24 hours after treatment is complete. Sexual partners should refrain from intercourse until a cure is established. Reinfection may result when the woman's partner is not treated. In particular, emphasize that all sexual partners should be treated and that condoms should be used with a new partner. Bacterial vaginosis. This infection, previously referred to as nonspecific vaginitis, is associated with organisms that replace normal lactobacilli with Gardnerella vaginalis or Mycoplasma hominis, or with anaerobic bacteria such as Prevotella or Mobiluncus. Causes of bacteria proliferation are not known, although tissue trauma and vaginal intercourse have been identified as contributing factors. Multiple partners, douching, and lack of vaginal lactobacilli are associated with bacterial vaginosis. Chief signs and symptoms are a thin, grayish-white vaginal discharge that typically exudes a fishy odor. The diagnosis is made by preparing a saline wet mount and identifying characteristic clue cells, epithelial cells with numerous bacilli clinging to their surface. Treatment for bacterial vaginosis is directed towards reestablishing the balance of flora in the vagina. Metronidazole has been shown to relieve symptoms and improve vaginal flora. Clindamycin is an alternative treatment. The woman should refrain from sexual intercourse until cured, or her partner should use a condom. Treatment of her partner has not proved beneficial. Chlamydial infection. The most common STD in Western countries is caused by the gram-negative bacterium C. trachomatis. The incidence is particularly high in sexually active teens and young adults. Chlamydial infection is often asymptomatic in women, which makes diagnosis and control of the disease difficult. It should be suspected when the male sexual partner is treated for non-gonococcal urethritis, and when the culture results for gonorrhea are negative, the woman exhibits symptoms similar to those of gonorrhea, such as a yellowish vaginal discharge and painful urination. Gonorrhea and chlamydial infections often coexist. Diagnosis of chlamydial infection can be made by isolating the bacterium in tissue culture, by enzyme-linked immunosorbent assay ELISA, or by direct fluorescent monoclonal antibody. Tissue culture of the organism is most accurate but requires more time. Untreated chlamydial infection ascends from the cervix to involve the fallopian tubes and is one of the chief causes of tubal scarring that results in pelvic inflammatory disease, PID, infertility, or ectopic pregnancy. Treatment is usually directed to eradicate both chlamydia and gonorrhea because the two often coexist. Treatment options include azithromycin, Zithromax, doxycycline, fibromycin, ofloxacin, Floxin, levofloxacin, Levaquin, and erythromycin. Treatment of all sexual partners is essential to prevent recurrence and further spread. Use of condoms until a cure is established is essential as well. Gonorrhea. Gonorrhea is an infection of the genitourinary tract that is caused by the gonococcus, Neisseria gonorrhoeae. Gonorrhea may be asymptomatic in women, but when symptoms do occur, they usually include purulent discharge, dysuria or painful urination, and dyspareunia. Diagnosis is based on a positive culture for the gonococcus. Gonorrhea is associated with PID, which increases the risk for tubal scarring and can result in infertility or ectopic pregnancy, as in chlamydial infection. Dual treatment of gonorrhea and chlamydial infections is often routine. Additional drugs to those previously discussed for chlamydia with gonorrhea infections include cefixime, Suprax, ceftriaxone, Rocephin, and ciprofloxacin, Cipro. All sexual partners should be treated simultaneously, and intercourse should be avoided, or the man should use a condom until a cure is confirmed. Syphilis. Syphilis is caused by the spirochete, Treponema pallidum, and it is divided into primary, secondary, and tertiary stages. The first sign of primary syphilis is a painless chancre that develops on the genitals, anus, or lips, or in the oral cavity. At the time, diagnosis is made by identifying the spirochete on dark field microscopy and material scraped from the base of the chancre. Serologic test results are generally negative in the primary stage. If untreated, the chancre heals in about 6 weeks. The disease is highly infectious at the primary stage. Although the chancre disappears, the spirochete lives and is carried by the blood to all parts of the body. About 2 months after the initial infection, infected people exhibit symptoms of secondary syphilis, including enlargement of the spleen and liver, headache, anorexia, and the generalized maculopapular skin rash. Skin eruptions, called condylomata lata, may develop on the vulva during this time. Condylomata lata resembles warts. They contain numerous spirochetes and are highly contagious. Serologic test results are generally positive at this time. If untreated, the disease enters a latent phase. They may last for several years. Tertiary syphilis, which follows the latent phase, may involve the heart, blood vessels, and central nervous system. General paralysis and psychosis may result. In addition to identification of the spirochete and material scraped from a chancre, diagnosis is made by serology. The usual screening test is the Venereal Disease Research Laboratory VDRL serum test, which is based on the presence of antibodies produced in response to the infection. Rapid plasma reagent RPR and fluorescent treponemal antibody absorption FTA-ABS tests are more specific and are often done to confirm a positive VDRL test. The best treatment of all stages of syphilis is with parenteral penicillin G. A woman who is allergic to penicillin can be admitted to the hospital for desensitization to penicillin, followed by administration of the drug. Herpes genitalis. Herpes genitalis is an STD caused by the herpes simplex virus, HSV. Two types of HSV have been identified, type 1 and type 2. HSV2 usually causes genital lesions, and HSV1 usually causes oropharyngeal infection. However, either organism may infect a less frequent location. Transmission occurs through direct contact with an infected person. A person infected with HSV1 develops antibodies that may reduce the severity of the first HSV2 infection. The primary HSV2 infection is one in which the person had no preceding HSV1 infection and therefore has no antibodies. Transmission may occur from a partner who is infected but has no visible lesions or symptomatic viral shedding. Within 2 to 12 days after the primary infection, vesicles, blisters, appear in a characteristic cluster on the vulva, perineum, or perianal area. The initial lesions may cause severe vulvar pain and tenderness as well as dyspareunia. Lesions also may occur on the cervix or in the vagina. Primary infection, the woman may experience flu-like symptoms, including fever, general malaise, and enlarged lymph nodes. The vesicles rupture within 1 to 7 days and form ulcers, take an average of 7 to 10 days to heal. When symptoms abate, the virus remains dormant in the nerve ganglia and periodically reactivates, particularly in times of stress, fever, and menses. Recurrent episodes are seldom as extensive or painful as the initial episode, but they are just as contagious. Diagnosis is often based on clinical signs and symptoms and confirmed by viral culture of fluid from the vesicle. No cure exists, but antiviral drugs reduce or suppress symptoms, shedding, and recurrent episodes. Antiviral drugs include acyclovir, Zovirax, famciclovir, Famvir, and valacyclovir, Valtrex. Women should be advised to abstain from sexual contact while lesions are present to avoid transmission to their partner. If it is an initial infection, they should continue to abstain until they become culture negative, because prolonged viral shedding may occur in such cases. Human papillomavirus. Condylomata acuminata, also known as venereal or genital warts, are caused by HPV. Dry, wart-like growths may be small and discrete, or they may cluster and resemble cauliflower. Common sites include the vagina, labia, cervix, and perineal area. Condylomata acuminata are of particular concern because of the association of HPV with cervical cancer. Colposcopy, examination by a magnifying instrument called the colposcope, is generally recommended to evaluate abnormal cervical tissue and to identify HPV. Women with condylomata acuminata should be advised to have Pap tests more frequently to detect cervical dysplasia, abnormal tissue development. The goal of treatment is to remove the warts, which easily transmit the HPV back and forth between sexual partners. Treatment is determined by the site and extent of the warts and the woman's preference. Topical treatment options include podophyllin, trichloroacetic acid, TCA, and bichloroacetic acid, BCA. More extensive warts or those that do not respond to topical therapy may require removal by cryotherapy, extreme cold, laser vaporization, LEEP, or conization. Interferon, an anti-neoplastic drug, is sometimes used to treat condylomata acuminata in women older than 18 years of age who have not responded to conventional therapy. The woman should understand that none of these treatments eradicates the virus and that she may have recurrences. Furthermore, all sexual partners must be treated. Sexual contact should be avoided till all lesions are healed, and the use of condoms is recommended to reduce transmission. HPV vaccine is discussed earlier in the chapter. Acquired immunodeficiency syndrome, AIDS, caused by HIV, remains the most devastating STD in the world today, although new treatments have improved the outlook considerably. HIV has been isolated from blood, semen, vaginal secretions, urine, saliva, tears, cerebrospinal fluid, amniotic fluid, and breast milk. Primary modes of transmission are intimate contact with infected bodily secretions, exposure to infected blood and blood products, and perinatal transmission from mother to infant. HIV testing is routine for all pregnant women, so treatment can be started if needed, possibly avoiding transmission to the fetus. A woman's risk for infection through a heterosexual relationship has surpassed the risk that her HIV infection stems from injectable drug use. Diagnosis of another STD is an indication for HIV testing, as is the patient who has repeated infections such as herpes virus or candidiasis. The healthcare provider should address concerns if a pregnant woman refuses testing or if she refuses testing with subsequent pregnancies because the first test was negative. Consent for HIV testing should be incorporated into the plan of care, verbally or written. Patients also have the right to decline or opt out of routine HIV testing. No medications have been shown to cure HIV and AIDS. Research continues about the benefits and safety of drug regimens that interrupt production of the virus. See Chapter 10 for a discussion of HIV and AIDS management in pregnant women and neonates. Updated guidelines for HIV and AIDS treatment and the pediatric, adult, and perinatal groups may be found at the AIDS Info website. Nursing considerations. As teachers and counselors, nurses can play a major part in preventing the spread of STDs and treat specific infections. Women must often be encouraged to use preventative measures to avoid infection, including HIV infection, from a man who does not want to use condoms as a barrier to infection. To fulfill this role, nurses should be prepared to do the following. Teach the signs and symptoms that require medical attention. Explain diagnostic or screening tests and follow-up testing needed for some infections. Teach preventative measures and follow-up care. Identify STD preventive measures that are compatible with age, language, male-female relationships, and the woman's culture, values for her own well-being, frequency of intercourse, number of partners, and many other factors that may be identified when the woman seeks care. Refer the woman to support groups and HIV specialists for best treatment options and follow-up if she has HIV infection. Pelvic inflammatory disease. PID infection of the upper genital tract is a serious health problem in the United States. About 1 million women develop PID each year in the United States, and many of them have ectopic pregnancy or infertility as added complications. Women who are under 25 years of age are more likely to develop PID because the cervix is not fully matured, increasing their susceptibility to infectious organisms that ascend into the uterus, fallopian tubes, ovaries, and other pelvic organs. Exposure to multiple sexual partners increases the risk for acquiring an infection that causes PID. Douching increases the risk for PID because it changes the natural vaginal flora that helps resist infection and pushes infectious organisms toward the uterine cavity. Etiology. Most PID cases are caused by C. trachomatis and N. gonorrhoeae infections. The remainder are caused by a variety of aerobic and anaerobic organisms, such as E. coli, G. vaginalis, Streptococcus, Group B Streptococcus, Peptostreptococcus, Peptococcus, Bacterioides species, Prevotella, Mycoplasma genitalium, Ureaplasma, and Cytomegalovirus. These organisms invade the endocervical canal where they cause cervicitis. Microorganisms ascend and infect the endometrium, fallopian tubes, and pelvic cavity. Chronic inflammatory response results in tubal scarring and paratubal adhesions, which interfere with conception or transport of the fertilized ovum through the obstructive fallopian tubes of the uterus. Inadequate treatment of vaginal infection increases the risk that the organism will ascend into the uterus, infecting deeper reproductive structures and causing PID. Symptoms. Signs and symptoms of PID vary widely. Some women are asymptomatic or have subtle symptoms, whereas others experience pelvic pain, fever, purulent vaginal discharge, nausea, anorexia, and irregular vaginal bleeding. Findings during physical examination may include abdominal or adnexal accessory organs, tenderness, and tenderness of the uterus and cervix when they are moved during bimanual examination, cervical motion tenderness. Laboratory evaluation may reveal a marked leukocytosis and increased sedimentation rate. A urinalysis is needed to rule out UTI. Cultures for N. gonorrhoeae, C. trachomatis, or other suspected infectious organisms help diagnose and best treat PID. Management. Women with serious infection, as manifested by fever, abdominal pain, and leukocytosis, may be admitted to a hospital. They are often treated with IV administration of broad-spectrum antibiotics such as ceftriaxone plus azithromycin or doxycycline, or cefixime plus azithromycin or doxycycline. IV antibiotic treatment usually can be changed to oral treatment after 48 hours, and the total duration of antibiotic therapy should be 14 days. Laparoscopy may be required to rule out surgical emergencies such as appendicitis or ectopic pregnancy, which have similar signs and symptoms, and to obtain specimens for culture. Pelvic abscess often requires surgical treatment. Outpatient treatment is appropriate for some women who are not as ill and will comply with the recommended regimen. Nursing considerations. Nurses can play an important role in preventing PID by teaching women how to prevent STDs in themselves and in their partners. Prevention can be thought of as occurring on two levels, primary and secondary. Primary prevention includes avoiding exposure to these diseases or preventing acquisition of infection during exposure. Primary preventative measures include limiting the number of sexual partners and avoiding intercourse with those who have had multiple partners, or other high-risk behaviors, such as injectable drug use, which is associated with HIV infection. Barrier methods, latex condoms, used consistently and correctly during all sexual activity, help prevent STDs. Secondary prevention involves keeping the lower genital tract infection from ascending to the upper genital tract, from being further transmitted within the community. This involves seeking medical attention promptly after having unprotected sex with someone who is suspected of having an STD and when vaginal discharge or genital lesions are apparent. Periodic medical assessment is necessary if a woman is not a mutually monogamous relationship, even if she is asymptomatic. Additional measures include taking medication as prescribed and returning for follow-up evaluation. Toxic shock syndrome. Although toxic shock syndrome is rare, it is a potentially fatal condition caused by toxin-producing strains of Staphylococcus aureus. The toxin alters capillary permeability, which allows intravascular fluid to leak from the blood vessels, leading to hypovolemia, hypotension, and shock. The toxin also causes direct tissue damage to organs and precipitates serious defects in coagulation. If toxic-producing strains of S. aureus inhabit the vagina, certain factors increase the risk that the toxin will gain entry into the bloodstream. These include the use of high absorbency tampons during menstruation and barrier methods of contraception, cervical cap or diaphragm, both of which may trap and hold bacteria if left in place for a prolonged time. However, about 50% of cases are not related to menses. Persons having had nasal surgery or previous S. aureus wound infections also have a greater risk. Symptoms of toxic shock syndrome include a sudden spiking fever, 38.9 C, 102 Fahrenheit, and flu-like symptoms, headache, sore throat, vomiting, diarrhea, hypotension, a generalized rash resembling sunburn, and skin peeling away from the palms of the hands and the soles of the feet 1 and 2 weeks after the onset of illness. Treatment consists of fluid replacement, administration of vasopressor drugs, and antimicrobial therapy. Corticosteroids may be used to treat skin changes. Nurses are often responsible for providing information that may be helpful in preventing toxic shock syndrome. Nurses should instruct women to do the following. Tampon use. Wash the hands thoroughly to remove bacteria before inserting tampons. Change tampons at least every 4 hours to prevent excessive bacterial growth on a tampon that is left in place for a long time. Do not use superabsorbent tampons at any time because they may be left in the vagina for a prolonged period, allowing bacteria to proliferate. Use pads rather than tampons during hours of sleep, which usually exceeds 4-hour segments of tampon use. Diaphragm or cervical cap use. Wash hands thoroughly before inserting a diaphragm or cervical cap. Do not use diaphragm or cervical cap during menstrual periods. Remove a diaphragm or cervical cap within the time recommended by the healthcare provider. Application of the nursing process, promoting women's health. Nurses may find themselves having the pleasure of promoting women's health rather than mostly finding problems with it. Promoting health can improve outcomes for families, not just individual women. This application of the nursing process is slightly different from the previous ones in that it uses a case study to demonstrate use of the nursing process, but also involves the woman in the process. Our reader should consider what he or she might do as a nurse. Assessment. Consider a 36-year-old woman who arrives for her annual well woman exam. She is overweight and states that she eats too much food and the kind that's bad for you. When giving her annual history, she states that many members of her family have diabetes. She also tells the nurse, "I don't want to be sick all the time like most of my family," and asks, "Can I change anything?" This single mother also describes her 6 and 10-year-old children as sitting around too much. Says that they are also overweight. She states that she wants her children not only to stay in school, but also to be more active. She is aware that increasing her children's activity level will help prevent excess weight gain. The woman is being seen for her WWE in an outpatient teaching clinic, and her care is provided by medical residents. She works at a fast food restaurant for varying hours per week. Health insurance is offered by the restaurant chain, but she cannot afford the premiums. She does qualify for Medicaid, so that is her major source of funding for medical care. Identification of patient problems. Although the woman has some obvious health problems and has financial limitations, she has indicated a personal desire to have better health for herself and her children. Her statements indicate that she is aware of the need to improve her actions, but does not know the best way. An appropriate patient problem for the woman is opportunity for patient teaching due to a desire to take charge of her own health and influence the health of her children in a positive way. Planning. Expected outcomes. Expected outcomes for this brief clinic visit are that the woman will do the following. Describe foods that she likes, can afford, and will help her lose weight. Explore how she might increase her own activity level and how she could include her children. Interventions. Reinforce the woman's desire for change. Recognizing that the nurse values her desire to improve her health and that of her children helps motivate the woman to search for ways to make changes she can accomplish over time. Explain how her actions to improve her own health set a positive example for her children, despite the family's financial limitations. Explain that she will have setbacks, but that she does not need to abandon her positive change to improve her health and that of her children. Identify food preferences. Determining what the woman eats regularly and what she enjoys the most helps the nurse identify beneficial aspects of her current diet and changes that might benefit her desire for better health. Ask her about food she eats during an average day, including the frequency and timing of meals. Ask her what food she eats where she works. Identify what vegetables and fruits she eats and in what form, e.g. fresh or canned fruits, fruit snack cakes that have very little actual fruit and may be more costly. Describe what is good about her choices and basic changes that she should consider. Help her identify beneficial changes from what she says about her personal preferences and explore ways to make those changes within her limited budget. Ask her if she eats breakfast and what she eats. Is it cereal with milk or is it leftover pizza? Explain to her that a nourishing breakfast for her and her children might be food that she had not considered. If she starts her day with adequate nourishing food, even if it is leftovers, explain that she is less likely to overeat or eat non-nourishing food later in the day. Drinking fewer soft drinks or bottled water might reduce an expense that the woman has not considered. She says her vegetables are canned. Ask if they are brand name or generic, and if she has considered using generic brands of food and other household products. Teach the woman that information about good nutrition is often available by computer, and that computers are available without charge at most public libraries. Financial assistance. Ask the woman if she receives any public assistance, such as SNAP, formerly the Food Stamps Program. Refer her to the appropriate source for information about qualifications and application if she does not receive public assistance. Referral to a social worker may identify other sources for food, such as free lunch program for children on school days or church or neighborhood groups that feed hungry people. Activity. Explain a daily activity helps her burn calories and can improve her energy level. Explore ways she might increase her activity, such as walking to work, the grocery store, or the post office. Help her evaluate whether it is realistic for her children to walk to school if she or another adult walks with them. What active games can she play with her children, perhaps at a nearby park? Evaluation. Although this encounter with the woman is brief, it's an opportunity for the nurse to reinforce her ability to achieve better health. As the woman lists food she often eats during a day, The nurse can promote those that are good for her health and or the health of her children, but also help her find alternatives to less nutritious foods. Finding that the woman has discovered ways to increase her family's activity level meets the second outcome and can motivate the woman to seek more opportunities that might be possible. The end.